great to see so many wonderful faces here, including some of the people that have been with Neuro from the very beginning, 15 years. So Neuro Challenge is now a 15-year-old. So, everything's so Dana in the back here, Dana Gilkey, has been with us from the very beginning. There's a couple more people around here as well that have helped us to get this off the ground. Initially, when we were just surviving off of no funds, no manpower, the community didn't know what we were doing. It's become such a wonderful, wonderful organization. Doreen just worked tooth and nail just to fight to get things done for Parkinson's in this community. And we were going to initially start out and just be in Sarasota, and then it was Port Charlotte, and then it was Bradenton, and now it's all the way up to Pinellas County and over to Sebring and down to Port Charlotte, Punta Gorda, places like that. So our organization continues to grow in a very healthy manner, providing free services for people all over the region. In fact, a lot of this is now online, and whenever we have symposia, sometimes they're live and people tune in from all over the country and including the world to watch them. So we've done a wonderful job of giving services to people who otherwise would not have them. And I know it makes a difference because I see it every day in my clinic. When my patients come into the clinic, they're so glad that they talk to one of the care advisors. That's probably the core of what we do, as Sarah was saying, is the care advising. Very, very important. So, as she encouraged you, if you feel like you don't know what's going on with your Parkinson's and you feel like you're not getting enough information, that's a good place to start. I think you'd be surprised at the broad range of information you would get from that. Okay, so I'm going to talk today about alternative treatments for Parkinson's and whether or not they're useful. And part of the reason I'm going to do this is because people come into my office every day with concerns about things that they read on the internet or they saw in papers or editorials or things. And probably the thing that I've heard about most recently is the tremor gloves. Has everybody heard about tremor gloves? Right? I mean, everyone's asking about it. 5 people have asked me about it today, so we'll talk about that a little bit. But for the people that are brand new here and have not seen my slides 15 times, let's talk a little bit about the basics of Parkinson's, symptoms, and then we'll talk about scientific evidence and what that's based on. And then we'll talk about the alternative treatments after that. So with Parkinson's, this is a picture of Michael J. Fox, and he's demonstrating some of the things that you normally would see. So he's got decreased facial expression. He's also got something in his hands that's called tenting. So it's usually one side more than the other. One hand will kind of tent, and the arm will not swing as well. People have difficulty with walking. Feet get stuck to the floor. It's called freezing or freezing of gait, also called fog. So people who have that freezing of gait, of course, that's dangerous, and they tend to fall. Eye movements, as you heard about earlier today, from Dr. Abrams, can be very restricted and also cause double vision, and that leads to additional risk for falling, as well as problems with reading and driving. With the cramping of the hands or the feet, there's something called dystonia that causes that. And dystonia can be not only disabling, but it can also be very painful. Handwriting, as you see, is small. This little example down here, something called progressive micrographia. So this person starts out with the word my, and then as it goes along, the writing gets smaller and smaller. Other things that are kind of below the surface that we don't really see. So if you see someone in a room with Parkinson's and they have a tremor, you might be able to say, okay, there's probably a Parkinson's patient, but 90% of what we deal with Parkinson's is below the surface. There's a lot of psychiatric involvement that we see. People who have depression, as Margarita mentioned, apathy is a big problem. Cognitive impairment, memory loss, maybe not so much like in Alzheimer's, but there is some memory loss with Parkinson's. And finally, hallucinations. And those things are all addressable individually. Sleep problems, there's one big one, it's called REM sleep disorder. Okay, so anybody in here wake up the next morning and then their spouse says, hey, you tried to beat me up last night, you were thrashing around and yelling and talking to me in your sleep. So I know that happens to people. I'm not going to ask you to out yourselves, but it does happen, and that can be very disturbing for your sleep. A lack of sense of smell is called anosmia, and if you can't smell something, sometimes that happens 5, 10, or 15 years before you even get Parkinson's. The autonomic system, or the system that kind of helps you to do things like digest your food and helps your blood pressure, that gets affected as well. So people tend to have constipation and a slow stomach. It's called gastroparesis or gastroparesis. They get filled up early. With the heart function, normally when you stand up, your heart gets a nice big pump so you get pressure to your brain and you don't pass out. With Parkinson's, that doesn't work so well, and so when people stand up, they get dizzy and their blood pressure falls instead it gets higher. Drooling is a very common problem as well. Another little push for Botox. Botox works in some patients, done that as well. Sweating episodes, erectile dysfunction, very common. So another thing people usually want to ask me when they come into the clinic is, where am I with my Parkinson's? What's going on? What's going to happen to me? A lot of them want to know where they're going to be in 5 or 10 years. There is a staging system that was developed mainly for research. It's called the Hohen and Yahr H&Y scale, developed many, many years ago. And this looks at different things you can see on a Parkinson's patient and help you to kind of put them into different categories. Yes. Yeah. And these categories we use not only for research, but also sometimes insurance companies want to know what the category is so that they can approve things like different therapies. So it goes from 1 to 5, with 5 being people being confined to a wheelchair or to a bed, and 1 being just a little bit of tremor on one side of the body, and there's different levels in between. I usually like to categorize people into mild, moderate, or severe Parkinson's, and sometimes you can even think of early, mid-stage, or late-stage Parkinson's. So this graph shows what happens over time with Parkinson's. So you see that red line on the top there that's going from left to right and going down. That's the number of neurons that are left in your brain that are still making dopamine. So that goes down over time. Those neurons die off. They also become sick and they don't work as well. So at some point during the dying off of those neurons, you then start to have actual symptoms. And those symptoms can be the motor symptoms with the tremor that we were talking about, or the non-motor symptoms, which are the autonomic problems we just mentioned. So that premotor phase can go on for quite a long time. So that brings up, how long you've had Parkinson's. It may be 10, 15, or 20 years before you actually become diagnosed. Part of the reason for that, we think, is because most Parkinson's is caused by the environment. It's something you're exposed to. So about 5% of patients have a genetic form of Parkinson's. So 95% of it is probably environmental or environment-gene interaction of some sort. So you're exposed to something. What if you just get a little bit of it? What if you are out in your garden and you're using some 7 dust or something and you get a little bit of it, and then 30 years later you wind up getting Parkinson's? Or alternatively, like when I was a kid, we did dumb things like ride our bikes behind these mosquito spraying truck, things like that. And so I'm just waiting for the other shoe to fall there. So. Or you worked on a farm, you're exposed every single day to pesticides. Maybe you're going to get Parkinson's a lot sooner than the other person. And that actually looks like it does hold some weight if you look at the scientific study. So on this graph here, you can see this light blue triangle down at the bottom, indicating kind of a slow progression of all these symptoms. And then eventually, as the time goes by, you get into the other stages that become more obvious. So another thing that we see is that people with Parkinson's, as I mentioned, some of them get it quickly and very early in their lives, and some people, it's very slow onset, it takes them a long time to get it, and it takes them a long time to get worse. Everybody's a little bit different with Parkinson's, which is why some people refer to it as a boutique disease or a smorgasbord. Different people have different rates of progression. And usually different people are on different types of medication, and they have different living situations. The rate of progression for you as an individual tends to progress at a rate that is predictive of what's going to happen in the future. So if you're progressing slowly, you're going to continue to progress slowly usually. If something happens rapidly, it's because something else is going on, like you have a urinary tract infection or pneumonia, or you're exhausted or fatigued, or something stressful has happened in your life. Without any treatment at all, it takes about 2 years to go from each of those 1 through 5 stages that I just went through on that scale, that H&Y scale. With treatment, it's probably 4 years for each of those different stages. So it takes about 15 to 20 years to get significantly debilitated with Parkinson's if you're treating it properly and doing a good job. So that includes not only medicine and therapies, exercise, right? Exercise, exercise, exercise. So we'll talk about that a little bit more. So here's a slice through two different brains. On the top, you can see the normal brain with this dark substance, and that's dopamine-producing cells in the substantia nigra. So those patients are the ones that are making a normal amount of dopamine throughout their lifetime. And then people with Parkinson's disease, you can see that that's washed out. This is not some special stain. This is just a normal brain that was cut up, and you can see on these patients that they had Parkinson's disease. And then on the other panel there to the right, there's a protein called alpha-synuclein, which is causing the Parkinson's, and that's building up in these cells. And at the far right, there's a big blob of this protein. It's called a Lewy body. So you guys probably heard of Lewy body. That's a Lewy body. And if you have too many of these in the wrong spot, then we call it Lewy body dementia. And Lewy body dementia is different, but people with Parkinson's get Lewy bodies, as do people with Alzheimer's and other diseases. But Lewy body dementia is a separate issue. Okay, so because people ask me all the time in my office about, again, different things, like they lay on a yoga mat, it's got a little magnet in it, and they feel like their Parkinson's has been cured, things like that. I thought I would talk a little bit about evidence-based medicine. So that involves using information gathered from the best available scientific studies to make decisions about medical treatments. Okay. So scientific evidence is based on statistics, study design. And there are a lot of things that impact that. So let's say in terms of severity or impact on the community or on individuals, pancreatic cancer is a very rapidly progressive, terrible type of cancer. And about 5% of people survive that over the course of 6 months to 2 years. It's really bad. So there's much more impetus to study that because you'd really like to stop that from happening versus dermatitis, which is a little bit of irritation of your skin, you go to the dermatologist. So in terms of impact on people, pancreatic cancer is much worse. In terms of prevalence, in other words, how many people in the community have something? ALS or Lou Gehrig's disease is very rare, right? So even though it's a terrible disease, very, very few people get it. There should be research to stop it, but at the same time, that versus coronary artery disease, which a lot of people get. In fact, most people have some probably as they get older. So that's a matter of prevalence. And with longevity, acute forms of leukemia untreated can take someone's life very rapidly, whereas if you have prostate cancer untreated, you could live for 20 or 30 years, depending on which type of progression rate you have. And finally, in terms of, again, rate of progression, ALS is a relatively rapid disease in terms of time to diagnosis to death, whereas Parkinson's is a relatively long disease. So those things all affect whether or not we can do studies on them. So how do we design studies for Parkinson's? Well, we look at how many people are available. So let's say you have a disease in children versus adults. Kids are in school. They're not going to be available to come in to do studies. Whereas adults who are retired or they have more time on their hands, frankly, and they can come and be involved in things. Is the treatment that you're offering to people going to be toxic or harmful? So let's say I told you if you electrocuted yourself, your Parkinson's would be cured. Obviously, very toxic, dumb, like it's ridiculous. But nobody's going to be enrolled in that study. Nobody's going to want to enroll in it. How long is the study? Is it 3 months or is it 10 years? Or some of these studies take 10 years. That affects it. Personal bias is also something we try to avoid in science, but it happens all the time. So I come up with a treatment, and I know it's going to be the best thing in the world for you, and I know when I give it to you, and I tell you that, and you're going to get better, because of this placebo effect. So bias affects all these things. Are there other studies which were done which were almost exactly the same, and now we're just doing a slight variation of that? That happens all the time, and it drives me nuts. People come in and they want to just do a slight tweak on something they did earlier, and it's like, well, let me do something more impactful. Funding of these studies is often hard because they are expensive. It can take, like for a drug study, it can take $1 billion to bring a drug to market. $1 billion. And for things that are not, that somebody can't sell so easily, like different forms of physical therapy or exercise, who's going to fund that? Because they're not going to make money off of that. It has to be some sort of charitable organization funding those. Manpower is also an issue. We have treatment, we have specialists, like movement disorder specialists and scientists in the lab who are few and far between. They don't have enough time to do all these different studies. Ethical issues come into play as to whether or not you should even study something that may, again, be harmful or could potentially not have any actual improvement upon people other than, maybe selling them a product. And then finally, the thing I think is probably most important in Parkinson's is this thing called power. So statistical power of the study. So something like 10% of patients, 10% of studies with Parkinson's are actually filled up. In other words, there's enough people in the studies to do the study and to complete it. 10%, that's terrible, right? So what results is that you don't have as many people to get a result. So look at these two different curves here. So you can see they look kind of similar. These are these bell-shaped curves everybody learns about. So they're about the same. Let's say there's only 10 people on each of those curves. Are they actually different? Well, statistically, it would be really hard to show that they're different. Now, if you look at a different situation, and now you've got 1,000 people on each curve, I mean, yes, visually you can look at these curves and say, okay, they're clearly different, but from a statistical perspective, it's even better. So the more people you have in a study, the more power you have, and the more likely you are to show a result. Now, you're probably wondering, why is he just beating the heck out of this horse here? Because I want to impress upon you that the things that we are going to talk about now, which you already know about, a lot of the treatments and things, have been scientifically studied and proven. Okay? And there's different levels of evidence we have for that. So at the very bottom, those are animal studies. Has anybody ever signed up for Google alerts or things like that about studies for Parkinson's? And it'll send you things about that have just come up. I have that on my Google account, and I get about 50 different reports every day from animal studies that are probably going to be a cure for Parkinson's. And so we know that animal studies don't necessarily translate to human studies, and that's a fact because in terms of all those things that we find that are going to be wonderful, very few of them actually pan out and get put into human trials, and then very few of those actually show us that they work. So there's one type of trial at the very top here. It says randomized controlled trial. That's probably the best sort of trial that we have. We'll talk about that in a second. And then finally, our best evidence is that once you have those randomized controlled trials, you have doctors at the top, the American Academy of Neurology and places like that, who are actually looking at all those studies and evaluating them, and they're the experts. And anything that's published in a journal should be peer-reviewed by experts. The worst type of evidence we have, we can call a house of cards sort of thing, where if you take one part away, everything falls down, or a Rube Goldberg machine, sometimes people say that. Publications that are not peer-reviewed, in other words, you write an article and you send it in and they go ahead and publish it no matter what. There's editorials. There's two different newspapers in this area. They look like medical newspapers, and you read the thing, and Dr. XYZ is treating back pain with this thing, and then you have somebody who will come and give a testimony about how wonderful it is, and that's not that useful because obviously it's an ad, and because testimonials are not real science. I mean, they may indicate something, but they're not real science. And then finally, anecdotes. I heard one patient come in and tell me that his uncle's friend smokes marijuana and it cured his Parkinson's disease. And there was a rumor going around about this for a while, about this special type of marijuana that's offered, and it's just not true. Okay, so this is a fun graph. There's going to be a test on this later. I want you all to be able to reproduce it. So if you can imagine, if you have any one of these components kind of break down, it could affect every single thing that's going on in this graph. But the other part of this is that there's a lot of things in here that are not defined, like this one thing says cytoskeletal dynamics. So what does that mean? Nobody knows. So my point is that these systems where somebody says, okay, I know that I can keep this one protein from interacting with other protein, and that's going to cure your Parkinson's. We can't say that. That's this house of cards argument. Or you see something on the internet, that shows you that they're going to help your Parkinson's, and then you go look at a video, and they give someone a pill, and they get better. And that's going to be, again, something that's not scientific, A, and B, a placebo effect. We'll talk about that. So randomized controlled trials are the best ones. People are randomly put into a group. Placebos are used for a control group. patients are often blinded as to which one of those they're getting, and even in the best studies, the researchers themselves, at least the lower level researchers, are also blinded. They don't know what they're getting. That's what you really want to see in real good studies. So the double-blind, placebo-controlled, randomized trial is this gold standard for these sort of trials. Okay, so people always ask me too, how come Parkinson's hasn't been solved? What's going on with that? There's no Parkinson's trials going on? No, that's true. There's billions of dollars going into Parkinson's research all the time. If you look on clinicaltrials.gov, there's almost 4,000 trials going on worldwide. If you look at how many of those are active, it's probably about 600 or so right now. And then 450 of those have an actual clinical treatment where they give someone a pill or some sort of, or the tremor gloves or things like that. 91 of those are funded by pharma companies. They're well funded, and about 29 current studies going on in the state of Florida. So there are some trials out there, but you have to get involved in them. Michael J. Fox Foundation has a nice part of their website. It's called Trial Finder. If you go on there, the Michael J. Fox Trial Finder, you can put in your age and your characteristics and say what you're taking, and then they can tell you whether or not there's a trial in your area that you can be involved in. Okay, so the placebo effect is very strong, not just in Parkinson's disease. If you give someone a pill, and it's a sugar pill, and you tell them, I'm giving you a sugar pill, I'm not giving you the real medicine, this is a placebo, guess what? They get better, okay? They know they're getting it, they still get better. The placebo effect is very strong in Parkinson's. It's probably about 15%, 10 to 15%. We see this all the time, and it lasts for quite a while. So this also kind of interferes with Parkinson's studies. And it also gets to, like that last slide I showed you with this pill, and they film someone, they give them a pill, and they film them again, and they're walking on proofs all of a sudden, and it's the placebo effect as well. But finally, placebos have been found in actual studies to release dopamine in your brain. Okay, so if you think you're going to get better, you get this brain circuitry that then releases more dopamine. So you can imagine that affects Parkinson's as well. And that can happen with anything. It could be pills, liquids, any physical manipulation, even with surgery. We've done a study where we took patients who were going to have implantation of stem cells into their brain. We did a sham surgery on some of those patients. We didn't tell them what we did. This was approved, and this was a while back. And the people who got the sham surgery got better. And that effect lasted. Okay, and that's a big placebo effect. So this is a study that was done a while back looking at a particular drug. And at the very start of that study, you see where it says 0 and those 3 lines going downward. Two of those groups, the ones that are lower down, were actually getting the medicine, but the one that's a little higher up that got better, they weren't getting the medicine. That was placebo. It happens all the time. So in terms of available medications out there, I'm not going to go through this list because there's many, many medicines that are out there. And they have their different effects, and a lot of them are based on levodopa or dopamine, and then ways that we can kind of play with that to help out. If there's any questions at the end, we can talk about medications if you'd like. Okay, now evidence-based medicine for surgery, there's lots and lots and lots of it. Deep brain stimulation surgery for Parkinson's disease has been approved for a long time. I hear patients come in occasionally and they say, oh, isn't this experimental? This just came out, No, actually in 1997 it was approved for Parkinson's tremor. 160,000 patients as of 2018, so 5 years ago, 160,000 patients had deep brain stimulation. So lots and lots of evidence, lots of follow-up studies. We know that it works. MRI guided ultrasound is, you've probably heard about that one. That's got approved just a few years ago for Parkinson's. That's using sound waves to burn part of the brain, and it's been approved, and it also works to some extent, so not exactly the same as deep brain stimulation, but if you're interested in either of those, you should talk to your doctor. Okay, so let's talk about things that are not approved by the FDA, medicinal treatments. Well, there's medications that are used for other purposes, like diabetic medications. Has anybody heard of this diabetic medication that was, there's studies in England that showed that if people who were on this medication were less likely to get Parkinson's? came out about 4 years ago, maybe. So that's being looked at right now as well. There's some calcium channel blocker drugs that also look like they were doing the same thing. That's being studied. Various supplements we'll talk about, and then stem cell treatments, and then hyperbaric oxygen. The only thing I'll say about hyperbaric oxygen is that it doesn't really work for Parkinson's. Okay, so different stem cell therapies. I mean, this is exciting stuff, right? You take a brain cell, or you take a fat cell, and you train it to be a brain cell, and you want to send it into the brain, you want to fix Parkinson's. Makes sense from that perspective. You can use fetal brain cells from fetal tissue studies, or you can use what's called autologous cells, which you take out your fat cells, you grow them up, or you take skin cells and you grow them up, and you revert them into these baby cells, and you train them to be dopamine producing cells. So far the evidence for IV stem cells, in other words, kind of taking them out of your fat, harvesting them, growing them up, putting them back in your arm, is pretty much non-existent. There's no good evidence for that, unfortunately. There was a very nice review that was done several years ago looking at 100 patients that had IV stem cell therapy, and they had a placebo effect in about 30% of the studies. People did get better for about 3-4 weeks, and then they went back to where they reverted back to what their normal baseline was. So IV stem cells don't work as far as we can see. And there's good reason to kind of think about why it doesn't work. Well, you already got the stem cells in your body. They're being made every day. In fact, you make stem cells in your brain, 5,000 every day. Brand new stem cells, baby neurons crawling around, wanting to know where to go. They haven't fixed the Parkinson's yet. So why is giving you 10 times more of them in IV going to help? It's true. So far, there's not good reason behind that. Now, stem cell implantation in the brain, in other words, taking dopamine cells and putting them into your brain, actually has a very long history, going back probably with brain implantation to the 1800s. And then in the mid-80s, people started putting dopamine cells in the brain. I'm not going to talk too much about this other than to say that the studies have been pretty encouraging in some patients. There's reasons why they work, reasons why they didn't work. Part of that is because we don't know where to put the cells, how many to put in there, what to do to make them survive, what sort of things should we give them to help them survive. And then, unfortunately, we've seen that in some patients who got those stem cells, after they died, we looked at the pathology, we looked at their brains, and some of those cells that we gave them that didn't have Parkinson's now had Parkinson's. So they got infected somehow with the Parkinson's protein. So these are all issues. And I think it is, down the road, I think it's going to be very exciting. There's great stuff going on at Harvard. There's people who've been looking into that here locally for a long time, Dr. Schumacher. So there are things that can be looked at, but it's still in the infancy of the studies. Okay, so what do we know about non-medicinal treatments? So we'll talk about different things here. LSVT-big, you just heard about. There's very good evidence for LSVT-big. This looks like margarita, but I don't think it is. So LSVT-big started out probably in 1987 or so, and there's many studies that have looked at the effectiveness, scientific studies, that show that LSVT-big does help. It reduces falling. Also, a really large patient study of 114 patients showed a 50% improvement in these different things called timed up and go, where you're in a chair and you stand up and walk, cognition and motor scores. So that's all good scientific evidence that it helps. And here's some people trying to fly away or hatch an egg. Part of the big class. And if you, after you're done with the big therapy here at Sarasota Hospital, then you get your little DVD and you go home and you do it every day. Okay? You have to do the exercises at home. And then power you just heard about as well. So that's an extension of the big, and that's more modifiable. And then loud actually was the first LSVT therapy that came up. And this therapy, as I mentioned, was to speak with intent, but it's been shown scientific results. It doubles your power for at least 6 months. After you take this course of LSVT loud, you can measure your voice volume, and it's twice as much power for at least 6 months. And they teach you different mechanics of how to straighten up and get a nice big lung full of air and project your voice and things. very effective. It's a marriage saver, frankly. And again, there's many studies that show that it helps, at least 50 studies, scientific studies. Okay, and then of course you can get a DVD and practice it later at home. Okay, so now let's talk about the tremor gloves. So tremor gloves were developed at Stanford, and they've been publishing information about this for about 2 or 3 years. Recently it was on, I think, the Today Show or something. There was a segment where they were talking about it. They did a small trial with 6 patients, and the patients wore these tremor gloves for about 2 to 4 hours per day. And it seemed to improve slowness, stiffness, and tremor. There was one part of this that suggested it could even help with gait. And this effect seemed to last a while after the gloves were removed, in other words, for weeks after this treatment. And there are different versions of these things. This has actually been looked at for many years, the tremor gloves. This is not the first type of study to go into this. And these are different ones that you can find on the internet that you can buy that do different things. So it kind of arose out of this idea that if you're having a tremor, why not give a vibration that counteracts that? Maybe that'll help the tremor. And there's a couple of case reports. One guy got on a train and he went across country, and the train was very wobbly and shook the whole time, and felt like his Parkinson's was better afterwards, things like that. So if you look at what's going on with that, there was a meta-analysis, which is where they look at all the different studies, done in 2021, and out of 1,200 or so studies, only 5 of those made comparisons to actually say it was a real good scientific study. And the vibration, whole body vibration therapy in those 5 studies suggested that it could help with walking. That's the only thing that came out of it. Acupuncture, acupuncture has been shown to help with stiffness and pain in Parkinson's patients. In terms of studies, there have been very few studies, but the ones that have been studied were looked at recently and showed that there's no real help with the motor function. But again, it helps with stiffness and pain. So I have sent patients for acupuncture, and they have told me themselves, they've come back and told me that it helped them. And again, that's like a case report. That's not a scientific study. But again, it's not a harmful treatment, right? So we'll talk about that in a minute as well. Over-the-counter drugs or supplements: curcumin, coenzyme Q10, glutathione, creatine. I'm not going to talk about creatine here, other than to say that it's kind of a muscle supplement that was relatively well studied with mixed results. CoQ10. Everybody's heard about CoQ10 for your heart function, maybe for Parkinson's, right? So there was a study that was done in 2002 where people were taking CoQ10 and vitamin E, and it looked like it helps their Parkinson's. So that was followed up in 2014 with a much bigger study, and they concluded it didn't help at all, unfortunately. Curcumin is something that's being pushed a lot by, I think, people in India have been using it for a long time for a lot of things as an anti-inflammatory, antioxidant. This is an excerpt from one study that was done that showed that the placebo effect was 3 times stronger than the actual effect of the curcumin, so it didn't work. And glutathione, similarly, kind of proposed as an antioxidant, has been shown in 2 different studies to really not be helpful. It doesn't work, unfortunately. In fact, Dr. Oken, University of Florida, one of his reports said, on the basis of these results, patients with Parkinson's should be encouraged to say no to IV placed in their arm for the false hope of symptomatic glutathione treatment. So, again, I think it tells you everything you need to know to avoid that. And a follow-up study was done with not IV, but with spraying glutathione in their nose, and it also showed a great placebo effect, but not a real effect. Okay, so just to summarize, if possible, treatment should be scientifically studied and reviewed by recognized experts. Randomized placebo-controlled trials are the best ones. FDA-approved medications for Parkinson's have been extensively studied prior to us giving them to you. They're not perfect, they're not perfectly effective, and they also may have side effects, but that's the best we have. Non-FDA-approved medications are experimental and should be presented or treated as such. Non-medicinal treatments for Parkinson's are sometimes approved by the FDA. modalities like big and loud are scientifically studied and proven to work for Parkinson's. Again, they're not perfect, but that's the best evidence we have. Over-the-counter supplements, unproven and in many cases disproven. Often experimental, so use your good judgment. If something is not likely to hurt you, it's okay to try it. And it may work personally for you. Sometimes we have those things that happen, and I'm not against that. I'm open-minded about that, as long as it's not going to hurt you. Placebo effect is very, very strong in Parkinson's. If you have things that you've heard about that you want to bring up and talk to, your doctor at the next visit, I have patients that send me urgent messages about things like tremor gloves, and I have to respond to them in 2 minutes or they're going to have a meltdown. so things like that, please hold that until you come to the doctor's office. Okay, so what do I always say? Take your medications on time, every time, right? Very important. I had a discussion earlier today with a gentleman who doesn't have that kind of wearing off and on-off kind of things. And for people like that, it's maybe not as important. If you miss a dose here or there, you're not going to pay for it. But most people with Parkinson's, as time goes by, they have to take their medications regularly or they're going to have that wearing off and they're going to have a real tough time. Exercise is medicine. It produces dopamine in your brain, and it may slow down Parkinson's disease by as much as 50%, according to a couple studies. And I have a talk on exercise, which probably you've heard before. Exercise is very important for a lot of things. Mood, it's probably better than taking an antidepressant. Flexibility, endurance, fatigue levels, so exercise is absolutely medicine. And then once the therapists who are here are done with you, you can't go home and go, well, that was fun. We see that a lot. People go home and they don't keep up with it, and they make these gains, and then they lose them rapidly. So you have to do the things at home that you were taught to do and to exercise on your own. Here's my favorite saying: being sedentary is like taking poison for Parkinson's. You can't be sedentary. I know apathy plays into this, but you should be doing something every day. Walking, stationary bike, swimming, lifting weights, yoga, tai chi, rock steady boxing, spinning classes, whatever you can do. And people say, what's the best type of exercise for Parkinson's? And I tell them, whatever you can do, whatever it is that you will do. So if you like pickleball, go play pickleball. You don't have to go into a spinning class, Vice versa, if you have a 3-wheel bike and you enjoy going on the Legacy Trail and things like that, great, good for you. But the key is to not be sedentary. Okay, so here's some of our people reaching for the sky. All right, so let me wrap this up. Let me go ahead and encourage people to ask questions. You have a so I think somebody probably has a...
keep your hands up, too.
Yeah, put your hands up, and there'll be a microphone that comes around.
Is there any really good way to diagnose if someone has Parkinson's?
Is there any way to diagnose it? That's a great question, and the answer is not really. We can look at symptoms and signs. If you go see a movement disorder specialist like myself, we have done studies of taking people who had Parkinson's or not and said, okay, go into this room and we'll see what the doctor says. And the doctor is ready to write about 70% of the time. Not great. There's a scan called a DAT scan, which is useful only in certain instances, and it's probably somewhere between 70 to 90% accurate. And there's a skin test, which again is about 60 to 70% accurate, so there's no one way to absolutely diagnose Parkinson's. Yeah, so he's asking if you should see a neurologist that specializes in Parkinson's. Of course, I'm biased. But I think the answer to that is yes. It's a very complicated disease that presents in different ways, and the average neurologist can probably diagnose it if you have typical sort of things, but not everybody does. Some people don't have a tremor, some people don't have walking problems, some people get early cognitive problems. So, yeah, I think you should see a movement disorder specialist if you're concerned about it.
I read online.
Hello?
I read online that Parkinson's behaves like a prion in a lot of ways. Is that a transmission concern for spouses or caretakers who are genetically predisposed to developing Parkinson's?
That is a great question. This is so interesting. So Parkinson's, we think, is not like a virus or a fungus or a bacterium. It's not a living organism, but at the same time, we know pretty well from studies it really looks like you can pass Parkinson's from one cell to the next, like it's called prions. These prions, you've heard of mad cow disease, right? So mad cow disease is exactly what that is. It's a protein that's flooding and misfolded, and then it teaches other proteins in the cell to do the same thing. And then it goes from one cell to the next one, and then, it's like an infection. It happens years. It takes years to happen. So we do think that that's a mechanism for Parkinson's. You can take a piece of a Parkinson's brain, a patient's brain, and put it into a rat, and you can do the rat Parkinson's. So we know that there is some infectious thing going on there. There is absolutely no evidence so far that it can be passed on through physical contact or intercourse or anything like that. So, and the best control we have for that is, people who are married 60, 70 years, one of them gets Parkinson's and the other doesn't, So I don't think there's any evidence right now that it can be passed on, through even through blood products, as far as we know.
Yes, you never touched on depression versus Parkinson's. My wife was diagnosed with depression probably about 20 years ago, and about 4 years ago she was diagnosed with Parkinson's. And we were told that depression is a precursor to Parkinson's, but we can't find any neurologist that would deal with both the depression and the Parkinson's.
So we know that depression is probably found in about 30 to 50% of people with Parkinson's, which is somewhere between 2 to 5 times higher than the average person, depending on which studies you look at. But it's very prevalent. And in fact, interestingly, 30 to 50% of caregivers of people with Parkinson's get depression as well. So we think there's partly a chemical component to that. Dopamine makes you happy. So does serotonin. Those two chemicals in your brain make you happy. You're not making enough dopamine, and that happens probably years prior to getting a diagnosis that you develop depression and anxiety for some patients. And we usually try to treat it with dopamine or the Parkinson's medications to see if that helps. But you're right, a lot of times people wind up going to psychiatrists as well as a neurologist in terms of getting treated for the emotional or mood disorder components to it.
Could you speak a little more about the work you mentioned that's going on at Harvard?
I don't know, I'm not completely up to date, but I know that at Harvard, they were looking into taking skin cells and then tricking them into being stem cells, and then, so from your own particular body, so your stem cells, turning them into stem cells, and then implanting them down into the brain. And they were doing monkey studies and doing safety trials and showing effectiveness, and I think what I heard, they were kind of ramping up to go back into doing some more human trials with that. So the technology for making those cells into dopamine cells, putting them in the brain, keeping them alive, I think has gotten a lot better. But those studies are very difficult. You have so many problems with things like making the cells stay alive and the person stay alive long enough to decide what happened with them. And there's a lot of issues there. But that's kind of my limited knowledge right now as to what's going on with that. Yeah, Dr. Sutherland, over here. Over here. Okay.
Have there been many studies on the effect of sugar intake on progression of Parkinson's?
Yes, but indirect studies that were looking retrospectively at people who had diabetes. If you have diabetes, your Parkinson's is worse, and it will get worse more quickly with uncontrolled blood sugar. So we think that that's not an effect on the dopamine-producing cells, but on the other brain cells. So people with diabetes tend to get little small strokes or mini strokes in their brain. They don't have any effect, like they don't lose control of their arm or anything like that, but they build up very slowly over time, and they cause what's called Parkinsonism, which is the stiffness and the hunched posture and the slow walking. And that, on top of your own Parkinson's, we think is kind of a double whammy effect. So, yeah, out of control blood sugar, diabetes out of control is definitely a problem with Parkinson's.
Is there any scientific studies going on? If it really some good statements saying that this could be our next fix? I mean, that you would recommend?
What's the question?
Yeah.
Are there any good studies out there currently for positive future of some of these trials?
Yeah, so I think for the first 30 or 40 years of the research, we were looking at treatments. And we're still looking at treatments, and we're improving those. But at the same time now, it's the shift its focus towards trying to find things that will slow down the progress or halt the progress. I think coming up with a cure for Parkinson's is a nice, we all want that. I think it's much more likely that we're going to find something that once you got diagnosed with it, or if you have the genes for it, is going to stop it from getting worse. And there's about 7 or 8 different compounds that people are looking at right now that help to clean up the cells and get the bad protein out of the cells. There's some promising stuff that's come out of that. I'm hoping that within the next 10 years we'll have something that you can take that will drastically reduce the progress of it.
Do you recommend like 4 of them or 3 of them that we could use and that we could spend time to give to? Give money?
Can you repeat that?
He said, would you recommend any of them that he could support, or the top 4?
In terms of the medications we're looking at?
Like the studies?
Yeah, I can't do that right now off the top of my head. I couldn't list them for you.
Could you comment on the relationship, if any, between restless leg syndrome and Parkinson's, and also what would you recommend for restless leg syndrome?
So restless legs and Parkinson's, good question. So the drugs that we use to treat restless leg syndrome, some of those are Parkinson's drugs. So we did figure out kind of backwards that those people had improvement when they're getting dopamine, just like people with Parkinson's do. So then we thought, well, maybe people with Parkinson's have restless legs. Maybe that's a risk factor. It turns out it's not, interestingly. Restless legs is not a risk factor for getting Parkinson's. People who have Parkinson's do tend to get restless legs if they're not getting their dopamine closer to when they go to sleep. They get achy and stiff. It's part of Parkinson's. So the treatment for people with Parkinson's is to modify whatever dose you're taking at nighttime, either to take more or to take a different form of it, to go on a patch. There's all kinds of different things that can be tried to try to get you a little bit more dopamine at nighttime.
Over here.
Would you comment upon the use of cannabis?
Cannabis?
Marijuana.
Medical marijuana. There's a guy out back that'll sell you something, but since states have kind of taken on the foot off the gas pedal there and allowed people to use medical marijuana, there are studies that have been out there, and they are building rapidly in terms of looking at tremor, dyskinesia, and sleep. I think those are the 3 things that may be improved with Parkinson's, with medical marijuana. CBD is very, very safe, and it's been taken off the controlled substance list. It's fine, you can try it. You can get it over the counter at Walgreens now. It's not a big deal. The THC component of it that makes you high is probably the more effective component in terms of helping with tremor, dyskinesia, and sleep. But then you also have to balance that with now you're taking the THC, which can make you goofy and confused. And if you have gait and balance problems, or you're really short of breath, or you have this orthostatic hypotension thing we were talking about, where your blood pressure drops when you stand up, that's probably not a good idea. Definitely want to discuss it with your neurologist, and then he would send you to a medical marijuana specialist, and then they would go through different ways to try that. So I think it's just like anything else. It's not a panacea. It's not going to fix everything. It has its place in a very small number of patients, and you have to be careful with it.
Over here.
I'm interested in the previous segment. They talked about this profound fatigue, and we're experiencing that fatigue that doesn't seem to be related to exercise, sleep, or medicine schedule. Is there anything known about what triggers that fatigue?
We don't know. We do not know. I've tried so many different ways to treat that fatigue. I've given people Ritalin, uppers. I've given them modafinil, which is another medication you can use for things like sleep apnea or other conditions. So I've given people stimulants. We've tried caffeine. We've tried high doses of caffeine. There's lots of things that have been tried. I think partly because we don't know what the mechanism for it is. It's probably also why we don't quite know how to treat it. So the short answer is no. That's it. Oh, I'm sorry. I've just been told we have to cut it off here. But thank you so much, everybody, for coming. April's going to come up and talk.